We'll go ahead and get started with Emily's housekeeping.
Good morning, everybody, or good afternoon. If you haven't done so yet, I invite you to mute yourself, and please don't take offense if we mute you during the call. This is being recorded. We've already hit the recording button. Towards the end of the meeting, I'm going to share a link in the chat box for evaluation. This is just a really quick survey for us to get feedback on how these can be improved. And if you're only joining us by phone and aren't on the email list, you can be added by sending me a note. And my email is efield, that's EFIELD @usetinc.org. And if you have any questions, put them in the chat or just ask them. That's all.
Thank you. And we'll go ahead and get started today with Christy Duke giving EPI updates.
Thank you, Brian.
So if you'll share, okay.
Thank you for pulling that up. As usual, we've seen an increase in testing and also an increase in the number of positives in the Nashville area office. And just like every Friday, it seems like the lawn guy comes and mows the lawn right in the middle of this presentation. So my apologies. He just came under the window. He's got terribly bad timing, so I'm sorry about that. We've got 26 sites reporting. Last week we had 13,027 tests. This week we tested a little over 1,000 more, so we are testing more. Number of positives rose from 1,337 to 1,424, and the number of negatives also rose correspondingly as well. So we are seeing more cases, and that kind of gels with what we're seeing across the U.S. There is a rise in cases across the nation and a rise in rates. You can go ahead and flip to the next slide, and we can talk about the actual rates. As we've seen consistently, our CHSDA counties, and this is all races, is higher than both the U.S. and the 13 states in which our tribes are located. We are now at 175 per 10,000, and that's compared with last week at 154 per 10,000. And we compare that to the U.S., that's now 120 per 10,000 compared with 106 per 10,000 this time last week. I'm going to go ahead and turn it over to Tori, who's going to talk about risk factors. But as always, please don't hesitate to contact us if you have any questions or if you have any questions over these numbers. Our email, just as a reminder, is usetepi@usetinc.org. All right, Tori, I'm going to turn it over to you.
Actually, we're going to Dr. Mira. So Dr. Mira, you're up.
Yeah, I'm sorry. Let me. Okay, good morning, everyone. I'm sorry about this. It's just that every other Friday I have the noon Cherokee Nation COVID update, and I just want to make sure I don't have to rush through the slides and jump out. So thank you. Sorry, Tori, for taking your place right now. I don't know if I showed this to you or not, but it kind of makes some points. It's not that it's that funny, but need to put things into perspective. Okay, so I'll cover a few CDC updates that I think are important and some treatment updates. So the first thing is that, let me show you some facts, and these are all published in the CDC website, and I have the references on this slide, on this deck. So it is known that concentrations of SARS-CoV-2 RNA in upper respiratory specimens decline after onset of symptoms. So unlike influenza, in which the highest peak of virus occurs one day after, a few days after the symptoms start, probably the highest peak of COVID or SARS-CoV-2 occurs the day before or during or the day of symptoms, and then it starts coming down. In patients with mild to moderate COVID-19, the replication competent virus, or in other terms, infectious virus, has not been recovered after 10 days following symptom onset. There is an exception though, in patients who are immune compromised or patients with severe infections, and severe is defined as hypoxemic or that you have a pneumonia that covers more than 50% of your lungs. In those patients, there's been at least 2 reports in which an infectious virus was recovered on day 15 and day 18 on another patient. So this subgroup of patients maybe have infectious virus up to day 20 after symptom onset. And we also know that high-risk household and hospital contacts do not develop infection, SARS-CoV-2 infection, if their exposure to a case patient starts 6 days or more after that case patient's illness has started. So if you got exposed to someone who got six days ago, you're unlikely to get infected from that person. The other things that we know is that recovered patients can continue to shed SARS-CoV-2 in their upper respiratory tract up to 12 weeks after infection started, or 90 days after symptoms started. But after day 10 or day 20, for those who are severely immune compromised, those viruses are not infections, they're just PCRs that are positive. And that has been demonstrated in several studies. The main one is the study of the 285 persistently positive persons in which they had 790 close contacts and none of those contacts got infected. This was from the South Korea CDC group. Another fact is that upper respiratory specimens from patients who recovered from an initial COVID-19 illness and later developed new symptoms, and we are seeing this more often now, and they retested positive, they did not have a virus that could replicate. The risk of infection may be lower in the first 3 months of initial infection. What this means is if you got COVID-19 now, in the next 90 days, you're probably unlikely to get infected again with COVID from another patient, based on the data that we have, and also based on other coronaviruses, which give a partial immunity in the first 3 to 4 months after the infection. And currently there has been no confirmed cases of SARS-CoV-2 reinfection in the United States for sure. There's 1 or 2 iffy cases from Southeast Asia, but they're not 100% confirmed. And all the references that make those facts a fact are here in case someone's curious. So based on those facts, what did the CDC decide to update us on? And it's 4 things, and I'll cover all these 4 in the next 4 or 5 slides. So the first one is, what are the recommendations for persons with COVID-19 regarding duration of isolation and precautions? So for most people, isolation can be discontinued 10 days after symptom onset and resolution of fever for at least 24 hours without the use of antipyretics and improvement of other symptoms. So what is the difference from the previous recommendation? The previous recommendation would say 72 hours. This was changed to 24. And the previous recommendation only included respiratory symptoms. This one includes other symptoms because we know there are more other things. Now, between my personal opinion, this could be complicated also to interpret, because if someone's symptom was loss of taste or smell, which we know can last for several months, I don't expect them to recover within 10 days. And that may not be an indication to keep them in isolation. So the definition is not perfect, but it's a good definition. Now, there's a limited number of persons with severe illness or immune compromise that may have replicating virus beyond 10 days and may warrant extending the duration of isolation for up to 20 days. So the main point the CDC is trying to make here is that we should not be using the test strategy to get someone out of isolation. We should only use the symptom-based strategy. But in those few cases of severely ill patients, patients with severe illness, meaning they're hypoxic or had a really bad pneumonia, or immune compromised patients, the test strategy may be appropriate if you want to get them off the hook after 10 days. But if you don't, you just do the 20-day isolation period. So for persons who never develop symptoms, isolation can be discontinued 10 days after the date of the first positive PCR test. That has not really changed. So just to put it on a visual perspective, if you have an immune competent host with a mild, not a severe infection, I have to improve this graph on that part. After 10 days, they are quote unquote immune to reinfections. And although they may have a positive PCR, they do not require retesting or anything else until they hit the 90 days. After 90 days, you reboot, everything starts again. For an immune compromised host or someone with a severe infection, it's 20 days. Now, if you want to take them off the hook here, you could do a test-based strategy, and if the tests are negative, 2 consecutive PCRs, then you can get them off isolation, or just wait the 20 days. So for what is the role of PCR testing after discontinuation of isolation or precaution? So if you look at this slide again, there's really no role for PCR testing in all this period, basically, for maybe one exception. So for persons who had a severe COVID-19 or a severely immune compromised, test-based strategy could be considered. That's what I just mentioned, if you don't want to do the 20-day isolation. For persons diagnosed with symptomatic COVID-19 who remain asymptomatic after recovery, retesting is not recommended within 3 months after the date of onset of symptoms, and quarantine is not recommended in the event of a close contact with an infected person. This is new. This is pretty interesting. So if you had COVID, you recovered, you're on your day 30, and you had an exposure, they're saying you don't have to quarantine that person because they're probably immune to that reinfection, at least for a 90-day period. For persons who develop new symptoms consistent with COVID-19 during the 3 months after the date of initial symptom or within that 90-day window, if an alternative etiology cannot be identified by a medical provider, the person may warrant retesting, and quarantine may be considered in the event symptoms develop within 14 days after a close contact with an infected person. So this gets a little bit more complicated, but the bottom line, and this is with consultation with infectious diseases. So let's go back to this slide. If someone during this period here develops symptoms and you cannot rule out other etiologies, like you cannot attribute those symptoms to strep throat, bacterial pneumonia, or UTI, whatever, then you may want to consider retesting and only quarantining them if they've been exposed to, or isolating them if they've been exposed to someone with COVID-19 and they have all those. That situation is pretty complex. But for the majority of the patients, nothing is required. There's no role for serology testing to establish the presence or absence of infection or reinfection yet. This may change, but right now we don't have that. And regarding healthcare personnel, this is where I get most of the questions. Really, it's the same rules. Most cases, the symptoms-based strategy should be used to determine when a healthcare provider can return to work, so you don't need to test them. But you may want to test them if they are immune compromised or had a severe infection and you want them to come back to work after day 10. That's where the testing may be used. Okay, shifting gears. This was a study published in MMWR. So, until now we thought that pregnant females did not have any greater risk if they get infected with COVID-19. So they CDC looked at reports of over 300,000 women on reproductive age who had a positive SARS-CoV-2 PCR test, and they found that 91,000, they had pregnancy data on 91,000 out of that 300,000, and of those, 8,000 were pregnant. So that's the group they compared to non-pregnant women, and they looked at several variables. So they all have COVID-19. Some are pregnant and some are not. They looked at hospitalization, and it seemed to be higher in the pregnant group. Now, there could be a bias here because maybe you tend to hospitalize someone just because they're COVID positive and pregnant at the same time compared to COVID positive and non-pregnant. So this could be a bias, but ICU admission shouldn't be biased. I mean, that means that you're really sicker. And the ones with COVID and pregnancy had more ICU admissions than the ones who were not pregnant and had COVID. And also when they looked at mechanical ventilation, that seemed to be higher on the pregnant versus non-pregnant. Now, interestingly, and the good news is that mortality wasn't really different, but all the other parameters were more significant in pregnant females. And now CDC they have not put pregnancy as a high-risk condition, but they put like in the middle, and we need more information, but I think we have to consider that this pregnancy and COVID could be a bad combination. Going to treatment updates, so there was another study on hydroxychloroquine in patients that were non-hospitalized and were treated within 4 days of symptom onset. And it was a randomized placebo-controlled study. There was no differences in any of the outcomes except for side effects, of course, more frequent on hydroxychloroquine. But then there was no difference on symptom persistence, on hospitalization or death. And I'll talk a little bit about this in a minute, but we now have dexamethasone as a proven, at least on one study, proven efficacy for patients with COVID-19, and I'll cover this a little bit more. There was one study that I did not put here because of time issues that said that hydroxychloroquine could be better, but it was not a randomized study. It had a lot of biases and flaws, so I didn't even want to waste your time on it. I think I forgot one. Okay. I thought I had more dexamethasone slides, and maybe I covered them on our last week presentation. But steroids given to patients who are hypoxic or who require mechanical ventilation show a benefit, and they do not show a benefit if patients are not hypoxic. So that's where we're using dexamethasone now. There is a prevention update. There is a vaccine that passed the phase 1 trial, phase 1 clinical trial. Basically what that means is that the vaccine made patients who got the vaccine produce neutralizing antibodies, all of them. They tested 3 different doses. The highest dose seemed to produce a lot of side effects. So probably when they move forward, they're going to use lower doses because all the doses produce neutralizing antibodies. But this does not mean that the vaccine is effective because you need the phase 3 clinical studies to prove that being vaccinated decreases your chances of getting COVID-19. What they've proven so far is that you do produce neutralizing antibodies and that certain doses do not produce side effects that would prohibit you to continue the trials. And I think this is good news. And just a little bit of humor at the end, because I think we need a little bit of humor in this pandemic, is the cat thing. And I'm done.
Great. Thank you for a wonderful presentation, Dr. Mira. Do we have any questions at this point for Dr. Mira? If not, we can move on to Tori Reeves.
Thank you for that that closing slide. I definitely appreciate that. I'm a cat lover as well, so I can relate. Thanks, Brian. So thank you everyone for joining. Today we'll just talk about the impact of COVID-19 on risk factors. Okay, next slide. So what are risk factors? The National Cancer Institute defines risk factors as something that increases a person's chance of developing a disease. So it's like a variable associated with an increased risk of disease or infection. So we will discuss types of risk factors later on in the presentation. Next slide, please. So why are risk factors important? Like, why do we care about them? So we know people with risk factors are more likely to need hospitalizations, intensive care if they have COVID-19, and they're more likely to die of the infection. Also, data shows that people with certain risk factors tend to contract COVID-19 at a higher rate and have poor outcomes, as we just said, like death, often require longer hospital stays, intubation, and they do have longer recovery periods. Okay. Next slide. So some of the types of risk factors, there are several. As you can see, we have age. People that are older in age have a higher chance of getting certain diseases. Gender, as we've seen throughout the data that males initially were contracting COVID-19 and having poorer outcomes than women. And I'll say later on in the slide that we do have some of the data to support that males tend to have a higher death rate as compared to women. Genetics also plays a role in determining if a person is more susceptible to certain diseases. Living in certain environments can also increase a person's chance of contracting a disease. These environments can contribute, such as through having poor sanitation or access to running water. Certain climates can contribute to a person contracting a disease. An example is people that live in a warmer tropical climate have a higher chance of contracting dengue fever than a person that lives in a cooler climate. Poverty also increases a person's chance of acquiring certain diseases, as having poor or limited access to quality health care, quality food, or adequate living spaces. There tend to be more generations living in one household compared to those of higher income status, which overcrowding increases the chance of contracting diseases, more people moving around and things like that. Being immunocompromised, this could be due to certain medications, pre-existing conditions such as HIV or AIDS. Cancer is another contributing factor. Again, medication, chemotherapy, and radiation can render a person immunocompromised, increasing their chance of contracting certain infections and other diseases. Next slide, please. Other risk factors can include obesity, cardiovascular disease, including heart failure, coronary artery disease, and sickle cell disease, and type 2 diabetes. There are lots of studies that are currently going on just to kind of determine how much the impact that this is occurring in communities. And again, like socioeconomic status also will be impacted by COVID-19. Those of poor tend to be a little poor, have longer to recover from COVID-19. They tend to maybe not even recover, such as like stores closing, small businesses, things like that. So these risk factors are not just impacting communities health-wise, it's also impacting communities financially through generations and things like that. Next slide. So what does the data show? Again, as I said, we will talk about this here. So 32.4% of all the deaths in the United States were in the ages of 85 and older. And that was again followed by the age group 74 to 85, accompanied by 26.4 deaths. The highest rate for hospitalizations was in people that were 65 years of age and older at 321.8 per 100,000. Non-Hispanic American Indian or Alaska Native persons have an age-adjusted hospitalization rate approximately 5.6 times that of a non-Hispanic white person, and non-Hispanic Black persons and Hispanic or Latino persons have a rate approximately 4.6 times that of non-Hispanic white persons. So as you can see, as we mentioned earlier, that race does have an impact, is a major risk factor for COVID-19. Males accounted for 53.8 of the deaths that are occurring from COVID-19. The study shows so far, and hospitalizations, you can go to the next slide. Hospitalizations occur at a rate that was 6 times higher in people that had underlying medical conditions compared to those who do not. And death was 12 times higher in these patients as well. So some of the main frequently reported conditions that we see with these hospitalizations and death was cardiovascular disease, type 2 diabetes, and chronic lung disease. So you can go on to the next slide. Thank you. So this last slide here just shows a breakdown of underlying medical conditions for COVID-19 laboratory confirmed hospitalizations, and it is broken down by pediatric, adult, and pregnant women. And you can see the differences in hospitalizations and things like that. So prevention is key for these risk factors. The goal is to, not get COVID-19 by practicing your social distancing, only doing essential movement to the grocery store and things like that, avoiding large crowds to make sure that you're not being exposed to the disease, and staying a minimum of 6 feet away from people just to, decrease your chances of contracting the disease. Next slide, please. And that concludes my presentation today. Thank you. If you have any questions, as always, our email address is here. Now I'll turn it back over to you, Brian.
Okay, great. Do we have any questions for Tori Reeves or Dr. Mira or Christy? Oh, we do have one question in the chat. Do we know what the symptoms are in cats?
So there's been 2 studies that I've seen, and those were the 2 studies I presented maybe a couple of months ago when this got reported in New England Journal of Medicine that cats could get infected. And from what I recall in that report, they did have a fever and some sneezed because they did develop a respiratory infection. So that those studies, they just proved that cats can get infected. But then after that, I have not seen any reports of being a problem regarding the epidemiology of the disease in humans. So I think it's safe to keep your cat and just keep them online. That's all. They're beautiful animals. They can be mean when they want to.
Thank you, Dr. Mira. Do we have any other questions for the panel?
No, but I wonder if cats, when they're sick, show like an unusually good mood, since they're usually pretty crabby. Maybe that's one of their symptoms.
Yeah, so just, if there are I don't know, are there any other questions or?
No, there's
no. I just want to comment that the reason I presented the data of the CDC today, when you go to the updates of the CDC, there's hundreds of updates. It's kind of daunting. And they touch on every single aspect, like, updates for businesses and schools and that. I'm a clinician, and the questions that I get pounded on, especially last week, is returning people to work, because now we're having shortages of staff. And also people that may not be healthcare workers, but they are critical in whatever employment they have. And the employers are requesting the tests. So the employers are I don't know if they're doing this because of a gut feeling or because that was a recommendation in the past, to have 2 negative tests before you can get off isolation. So it's causing a lot of problems in returning employees to work. And the CDC explicitly recognizes this in their webpage. And that's why they are moving more for a symptom-based strategy and not a test-based strategy. And the other thing is that we don't have enough tests to do all the tests that we really want to. And that's another way of saving tests that you really don't need. So I just want to mention that because it seems to be a problem everywhere.
So that is a good point. And I just ran across a CDC article this morning that I sent to the staff that they probably not had the opportunity to read. But it was CDC on returning to school. And I have to say, I need to dig more into the evidence, but I'm pretty disappointed in the CDC's take on the return to school. And I wondered if you had read that. I think it just came out recently, yesterday or day before, and your thoughts on that. But, you know, it's all about how important school is, and children need to be in school, and what happens if they're not in school. But what are your thoughts on that, if you had a chance to read it?
No, okay, I have not had a chance to read it. I did heard some negative comments about it yesterday in some medical medias and also some in the news, in the general news media. And so, you know, when I read it, I'll give you more information, but I kind of, I probably know what they're going to be saying. And I don't think you can make a blanket recommendation for everywhere. You know, each site is different. So if you live in a community with a very low incidence of activity of COVID in your community, it may be safe to open your schools with all the precautions that you need to take, right? Social distancing, mask use, etc. And even if you have a good testing, to do frequent testing, you know, asymptomatic testing to detect. But if you're in like in Oklahoma right now, that we are at full capacity, our hospital has more COVID patients than anything else admitted right now. I would not even dare open a school, especially after, I don't know if you had the opportunity to read the study from South Korea, CDC of South Korea. It was a contact tracing study, and they looked at all ages to see when they went back home, how many households got infected from the cases, and they stratified it by age. So in that study, the highest risk was being 10 to 18 or 19 years old. Those were the highest transmitters. The children less than 10 years old apparently were less transmitters. But it's just to break with that false statements that we hear all the time that, oh, children are not a problem, children do not transmit the disease. And according to that study, they do transmit the disease, and they transmit it, depending on their age, more frequently than adults. So I think it's a dangerous business to do that. And this is not scientific, what I'm going to mention. I saw this on the news last night, that they were criticizing our president because he canceled the Florida, you know, whatever rally he was going to do because it's not safe, but it's safe to open schools. So, I mean, make up your mind. It's safe or it's not safe. I think that you should be cautious and use all the science that we have. And you cannot make a blanket recommendation. You have to individualize each situation.
Yeah, as I was skimming, and I just skimmed it this morning, but I keep seeing reference to school age children, you know, and with the recognition that school age is 6 to 18. So, I mean, I know what they're referring to here. They're referring to what you said, younger children, I think. But it just, I take issue with the article, and I'd like to, with my staff, discuss it further and maybe issue a recommendation from the USET TEC based on some of those considerations. And, you know, I mean, in Indian country, we've got additional considerations too, with the high comorbidities, the concern about losing culture, especially amongst the Eastern tribes who, you know, maybe just have few native speakers left. So that may be something that I need to discuss with our staff, but I think that does need to come because I have some concerns about what the CDC issued.
We have a question in the chat. How far down the line of contact does one need to quarantine, and for how long? Hearing questions around someone having contact with someone who had contact with someone who tested positive.
Okay, how are down the line of contact? Okay, so you don't intervene on a contact of a contact. You only do the intervention on the primary contact. If I'm understanding the question correctly. But for example, they say, the typical question we get is, my husband just was told at work that he was a contact of a COVID positive case. So what do we have to do? Well, the husband has to be, if it's true that he was a close contact, he needs to be quarantined. But then the rest of the family do not need to formally do anything, except we recommend be just vigilant of your symptoms, because I mean, there is a chance that, let's say that husband got the infection, is asymptomatic, and could be transmitting it to the rest of the household. That is a possibility. So we just recommend, self-monitor, and the general recommendations, wear a mask, keep social distancing. And if you have any symptoms, please, come in and get tested. Now, if that contact ends up getting infected, then yes, they become contacts now, and they would have to quarantine. And the infection rate of households varies depending on what study you see, but it's around 20%. So your odds, even though it's high, it's not as high that you say everybody's going to get infected. And what we've seen here, that it depends on the spreader capacity of that case. That we've seen households that they've all gotten infected, and then we see a household in which none of them got infected. So I think there's other variables that we don't understand what makes one person a super spreader compared to other ones. But the answer is no, you don't do anything formally. I don't know, Christy, if you have a different perspective, but that's what I know from the guidelines.
We don't, and that's what we've been recommending as well. I mean, theoretically, people should be reducing their movements anyways, and that's what we're recommending, and taking the social distancing precautions seriously. So, I mean, at some point, you've got to cut off the contacts of the contacts of the contacts.
Right.
But yeah, I would agree with you. Imani, Tori, have you seen anything different?
No, this is Tori. I haven't seen anything saying I agree with you both.
Well, and you think about, the incubation period and of the first contact, and then the time that they take to develop symptoms. And if they do pass, so, I mean, there's a lag time there. It's not, so yeah, I think that just the contact itself.
So let me share a question I got today with the group, because I have my opinion, but I did not have have time to look at the web pages and find the answer. So I got a question from OBGYN department saying, should we, because we're having some shortage of personnel here and there, so sometimes nurses from the OBGYN department get pulled in to go to med-surg, where we have all our COVID positive patients. And the question was, should we really be doing this? Is it safe? Because then these nurses come back and they are dealing with newborns and pregnant females. And so what would you recommend? And so I want to know if is there any guidance, strict guidance that anybody has heard of having the personnel of OBGYN minimize their exposure with other COVID positive patients?
I've not seen anything. Tori, Imani, I don't know if you've seen anything. I guess it would be an opinion too, which I would issue, is to try to restrict movements to close the loop as much as you can. But then, if you're weighing patient safety and you're jeopardizing patient safety because you don't have enough staff, I mean, that's really hard to compare risk to risk there. And, if providers are wearing N95s and taking universal precautions right now, then I guess my opinion would be to send the staff where they're needed. I mean, but that's a hard one to answer. What are your thoughts on that, Dr. Mira?
Well, I mean, basically what you said, I said, look, I agree that, I mean, certainly there's got to be more risk of getting COVID if you work in a COVID unit than if you don't. I mean, you're just being more exposed, and you can be as careful as you can, but sometimes you breach accidentally some of the guidelines. But so if you have the option of not sending your personnel there, I would say it's safer. But if you need personnel because you need nurses, then that takes a priority, and you just need to be as careful as you can. The other thing I said, well, maybe if you can't do that, we may consider periodic testing of your personnel, just to make sure that someone doesn't slip through the cracks and comes back with the virus, and we can detect it earlier. That could be an option. But I said, let me look. I mean, I don't have it on top of my head that I've read anything specific regarding a recommendation for this, for OBGYN units. But it's more like what you said, Chris. I just gave my gut feeling response, and I was wondering if there was a CDC specific guidance on that, or any other, academic institution guidance on that subject.
Tori, Imani, can you chime in on this? Do you have any thoughts, even if it's just an opinion? And that I think that question, as this drags on and staff are starting to get burned out, it's probably going to crop up more and more.
Sorry, go ahead. Sorry, Chrissy. No, I'm sorry, I didn't hear the question. What was your question, Chrissy?
That's okay. Just on the thoughts that Dr. Merritt had a question about nurses being pulled off of med-surg or other areas to go work OBGYN, and the risk factors for bringing COVID into labor and delivery in the hospital. And, they've got to weigh patient safety, because if they don't have enough staff in labor and delivery, that's just a really hard question to answer. And I've not seen any guidance. Go ahead.
No, so in this situation, it was labor and delivery has plenty of staff, but the med-surg is the one that is requesting more staff. So they pull some of those nurses from OB, but then they come back. Okay. So that was very similar to what you said, but that was the exact the concern they had.
Yeah, I haven't seen any guidance on it, but I have friends that are working in the field, and they've been pulled from other departments to go support like med-surg and ICU and stuff like that. And they just, once they're finished helping, they just go back to their regular shift, their regular department. And some haven't even been tested, even if they've been exposed. So there's nothing in place at most facilities to protect the mom or anything like that. So I think it would be interesting to see what the data shows and what the recommendations are when they come out.
And I will say, just kind of thinking through this, and I could be wrong because I'm trying to conceptualize this. Ideally, what I would like to see, and I know some hospitals have already done this, and I've heard of them having the COVID positive patients as that being the closed loop, so to speak. So if they come into the ER or whatever, and then they have a COVID ward, I know some hospitals are only taking COVID patients, other hospitals are taking no COVID patients. So trying to separate out as much as they possibly can on that front, and maybe not, just in the ICU or in a room or whatever. So, but that's a really hard question. Does anybody have anything else? Anything that they want to discuss? We've kind of just been throwing things out here today at the end. I jokingly said to a colleague the other day, when this first started, that pretty much this whole pandemic sums up to a very professional, I don't know, nobody's looked at that before. And that seems to be happening across the board, that there's still a lot of answers that we do not know the question. I mean, a lot of questions we don't know the answers to.
Right. Do we have any other questions or thoughts for today's call? If not, there's the SurveyMonkey survey in the chat box. And please fill that out. It's very short, it's brief. And have a great Friday.
Bye. Be safe.
Thank you.